Namaskar dosto, welcome to channel Toxicology on board. Today in this video we'll discuss in continuation with ethanol toxicity only. The questions which are given under AACT that we will discuss, and towards the end of the presentation we'll also discuss ICH Q3C class 3 solvents, how ethanol is listed. Okay. So first question is a variety of non-instrumentation so-called field sobriety tests are used by law enforcement across the USA and around the world. What is the reliability of these tests in discerning ethanol intoxication? So there are different types of tests are there, like hand pat test, finger to finger test, finger to nose test. Such tests will be there. So all of these sorbidity tests have been subjected of remarkably few published peer-reviewed studies and most show weak correlations with the blood alcohol concentration. Okay. Second question. What is the so-called standard drink? So how we are going to measure the concentration of the alcohol in that particular standard drink? What is the definition of the risk drinking in terms of consumption of standard drinks? So if you look into a standard drink, no, it contains 14 grams of ethanol and is exemplified by 12 ounces of beer, 5 ounces of wine, and 1.5 ounces of 80 proof liquor. Risk drinking, if you see in the males, no, in the men, it is 15 or more standard drinks per week, or 5 or more on an occasion, 8 or more drinks weekly, or 4 or more on an occasion in the case of women, or people who are older than 65 years of age. So this is the definition of the risk drinking. These questions are discussed from American Academy of Clinical Sciences, that comes under question of the day. Okay, so we have next question. What is the average ratio of serum ethanol concentration to blood ethanol concentration in the case of human beings? Okay, so we need to know, in other words, how does one convert serum ethanol level into whole blood ethanol levels? Average ratio of serum ethanol to blood ethanol has been reported to be 1.15 is to 1. Okay, the range is 0.88 to 1.59. Dividing a measured serum alcohol concentration by this 1.115 results in the estimated blood ethanol concentration. Okay, this is very important. Next question. Following death, to what degrees does the decomposition of the human body generate detectable blood ethanol levels? Okay, so the data are consistent with the previous study, suggesting that decomposition is rarely an important factor in causing increase in that blood ethanol concentration above 70 mg percentage. But further study needs to be undertaken in order to prove this particular point. Next, what is the proposed pathogenesis of hypoglycemia associated with this ethanol toxication? So, pathogenesis of this particular hypoglycemia phenomena has not been proven, but what are the important likely result of inhibition of this in the liver? No, gluconeogenesis is inhibited. Ethanol metabolism increases the nicotinamide adenine dinucleotide, which we have seen in the mechanism NAD, converting to NAD and H plus proteins. NAD is depleted and it will interfere with the formation of glucose from its precursors. So this phenomena is more likely in the case of individual with reduced, in which liver resources of this particular glycogen, particularly in the case of young children or who are undernourished individuals or no, they are going subjected to have this particular pathogenesis of hypoglycemia because of this ethanol intoxication. Next question we'll see, what drug is most commonly implicated in the death that occurs in hot tubs as well as saunas. So whenever you are consuming alcohol along with some other drug, so primary drug contributes to death is ethanol along with cocaine. So whenever you are taking ethanol with a recreational drug like cocaine, it will form cocaine and ethanol in combination, and second most drug related to this type of deaths. Okay, coca-ethylene will be formed, which is given in the Clayson textbook. The compound ethyl glucuronide has been proposed as a biomarker for ingestion of what substance? So we need to identify. So what substance has been proposed to be a biomarker for this? So answer will be Ethyl glucuronide has been proposed as a biomarker for the ingestion of alcohol, that is ethanol. Marker be applied in the case of urine sample, serum sample, as well as hair testing. Challenges which are associated with these factors are, with respect to, you are unable to distinguish between whether it is because of this drinking or that alcohol source is coming from non-beverages. Okay, and non-uniform reporting, sample stability, the various factors are there. Okay, because of which they will make much more challenging to make ethyl glucuronide as a biomarker for this alcohol consumption. Next question is, what is the basis for anti-abuse reaction, that is disulfiram mediated alcohol intoxication? So anti-abuse, common name is disulfiram. What it will do, we have two important enzymes, alcohol dehydrogenase, aldehyde dehydrogenase. Disulfiram will inhibit this particular aldehyde dehydrogenase. As a result, what happens, acetaldehyde level in your blood will increase. So this enzyme, uh, aldehyde dehydrogenase, that metabolizes acetaldehyde. The product of this metabolism of ethanol mediated. So whenever the acetaldehyde levels increases, no, you will have headache, nausea, palpitation, facial flushing. Important thing you have to remember, anti-abuse reaction, disulfiram inhibiting aldehyde dehydrogenase. Next question is, what is the best way to determine if a post-mortem ethanol level reflects anti-mortem alcohol per ingestion? So after fermentation of the particular dead body, uh, is the alcohol level increasing or is it because of the alcohol consumed? That how you are going to differentiate if a post-mortem ethanol level reflects anti-mortem alcohol ingestion or post-mortem alcohol fermentation. Okay, so the right answer we'll see. Best way to collect the particular sample is vitreous humor. So vitreous humor. So here you are collecting, may be used as a testing substrate to differentiate pre-term pre-mortem alcohol ingestion from post-mortem alcohol fermentation, as fermentation generally does not take place in your eye. So here the alcohol which was before post-mortem, that will be there, not anti-mortem. Okay, not because of the fermentation of the dead body. Next question is, what is the fractional conversion of cocaine to cocoethylene? So we have got two more questions. Ethanol with cocaine. Okay, in the presence of substantial blood alcohol concentration, approximately 17% cocaine is converted to cocoethylene in the presence of substantial blood alcohol concentration. So in the Glaser textbook only it is very clearly given. Alcohol, when it is combined with cocaine, cocoethylene is formed, which act as a synergistic or potentiation type of action will be there. Next question is, emergency physicians and nurses often draw blood from patients in order to determine the blood alcohol concentration. When the skin is prepared for the swabbing, no, they'll rub alcohol. That's why I always say read in the Clayton textbook also they have given methanol, ethanol, isopropyl alcohol, which is a rubbing alcohol. So what is the skin? When the skin is prepared by swabbing with isopropyl alcohol containing pads, what is the likelihood that the blood alcohol concentration will be falsely elevated due to application of this isopropyl to the skin? Actually, that is completely negligible levels. So you read it, there are certain legal authorities where they say that always try to use this swabbing pads which do not contain alcohol. If even if it is containing that one, the amount of that reaching into your systemic circulation is very less through skin. So that is, it is highly unlikely that use of prep and pad containing isopropyl alcohol will cause false elevation of this blood ethanol levels. Okay, stop the video, you yourself read about this explanation which is given by the AACT. Then next question is, name four common household non-beverages products that may contain ethanol. So when we discussed about ethanol also in Clayson textbook, because of its ubiquitous nature, no, it is found in lot of household products, pharmaceutical products. Here you see, it is there in the mouthwash, aftershave lotion, hairspray, and cough and cold preparation. They have given different concentration of alcohols also in each type of product. What is the effector which is associated with coprinus atramentarius ingestion? So this particular thing is, no, it is a type of mushroom. So this mushroom, no, It is similarly giving to the just now we read about anti-abuse reaction, disulfiram reaction. No, so this particular this mushroom fungal mushroom, it is releasing this particular toxin called coprin. What is the mechanism of this coprin? Is it is going to inhibit aldehyde dehydrogenase. As a result, acetaldehyde level will increase and it will cause same type of symptoms. So coprin, it is a major metabolite which will inhibit this aldehyde dehydrogenase. Ingested with ethanol, acetaldehyde levels will increase and it will cause flushing, nausea, and vomiting. Okay, same like the disulfiram type of effect. Next question is, what are the likely mechanism of ethanol action as a teratogen? So we have seen in the Clayson textbook also, ethanol has been listed under human developmental toxicants. So what are the different mechanisms we'll see? It is going to cause reactive oxidation species generation as a byproduct of this CYP2E1. So second way of pathway is CYP2E1, no? Decreased antioxidant levels, mitochondrial damage. So one of the location where cytosol, mitochondria, endoplasmic reticulum. So it is lipid peroxidation which is taking place in the liver. Disrupted neuronal cell adhesion we have seen in the case of fetal also. Placental vasoconstriction, inhibition of cofactors required for fetal growth and development. So these are the reasons why you have cranial dysmorphism will be there. Okay. Now that was the important questions which are given in the AACT. So now along with that, in this video we will be discussing completely different point. If alcohol used as a solvent, we already know that it is used as an industrial solvent for the pharmaceutical preparations also it is used as a solvent. So it is being listed under ICH Q3C guideline. Under that also they have given under table 3. So this, if you look into this table 3, no, it talks about the solvents which have very low toxic potential. So by default they have given for class 3 solvents they have given 50 mg per day or corresponding to 5000 ppm. So these are the list. In that ethanol is also there. Okay. So pause here or you go back and read. And currently ICH Q3C guideline is under revision 9. Okay. In addition to that, in the Appendix 6 only, they have given how they have calculated ethanol PD considering various studies. Okay, even though at the end we are for the risk assessment in your specifications you are keeping 50 mg or whatever the 5000 ppm, that is the limit. But in the Appendix 6 they have given different type of studies from which they have derived the PD. So pause here. Those who people want to learn, they can understand. I am not going to explain. You read about how they are converting the dose conversions from ppm to mg per meter cube and mg per liter. Okay, and what how they have considered the various factors. Okay, and here if you look into the first study, no, here they have considered NEL. No, no. So earlier, before pre-GLP, there used to be NOEL. There used to be NO. Now it is NOAL. Earlier, pre-GLP studies, if you see most of the studies, you will have point of departure of as NOEL. Here they have considered NEL actually. Okay, like that. You pause here. You read, and they have considered see cleft palate, maternal effects. These are the things they have considered under severe adverse effects, and you can see that F4 factor they have taken here as F4 they have taken as 10. Okay, so hope and if you look into the references also you can see ACGH, which is a part of ABT syllabus brochure, no? And ethanol it is used as a direct food additive. It is been listed under 21 CFR this particular thing. Okay. Um, Hope from this video you were able to understand the important question areas where even AACT is asking questions, and we had a very quick revision with respect to ICH Q3C guidelines also. You can go back and refer the guideline to understand in detail how the conversions are there. Okay, thank you so much. Be curious. For any questions, you can always write a mail to arya.priyanka18@gmail.com. All the best for your exam.